Hi, everyone, and welcome. Thanks for joining us. Today's presentations and moderated discussions will be led by Women in Endoscopy and sponsored by AMBU. My name is Hannah Vassar from AMBU, and I'll be introducing our speakers and our presentations. The presentation is going to be recorded and available on the WIE website for viewing later if you have any colleagues to invite that may have missed tonight's show. So during the event, if you have any questions or comments, please submit them at the bottom of your screen using the Q&A tool, or you can actually put them in the chat box. For today's agenda, we have two presentations and a moderated discussion. The first presentation will be presented by Dr. Shivangi Katari from the University of Rochester Medical Center. It is entitled Life Beyond Lockdown. The second presentation will be presented by Dr. Rabia De La Tour from NYU School of Medicine and is entitled Ergonomics and Endoscopy. Our moderators today are Dr. Unji Shen from Johns Hopkins University School of Medicine and Dr. Amrita Sethi. To kick us off, Dr. Sethi will be providing a brief introduction on behalf of WIE. Welcome, Dr. Sethi. Dr. Sethi is an interventional endoscopist at Columbia University Irving Medical Center in New York. She's an associate professor of medicine, director of interventional endoscopy, and program director of the Advanced Endoscopy Fellowship. In 2016, Dr. Sethi founded Women in Endoscopy, previously known as Women in Interventional Endoscopy, and currently serves as the president. Last year, she was awarded the Master Endoscopist Award by ASGE. Thank you, Dr. Sethi. The floor is yours.
Thank you so much, Hannah. It's a pleasure to be here today and to be able to be part of this great event. On behalf of Women in Endoscopy, WIE, all of the presenters, and hopefully all of the audience, we thank you and AMBU for your support. Women in Endoscopy is a global organization that champions the advancement of women through education, professional growth, and leadership development. As you mentioned, we've been here for a number of years now and have been able to develop a large membership from around the world and be able to provide meaningful events such as these webinars, as well as networking, mentorship, and look forward to ongoing plans. As you can see here, this is our board. We do have board members from around the world representing membership from around the world. And we also do have male board members and members. And so we encourage all participants and attendees to join us. If you want to become a WIE member, you can go to www.womeninendo.org, as you'll see on the next slide, and become a member there. There are many ways to get involved, including being part of different committees, as you can see here, trying to address all types of topics, and again, help promote women in the field of endoscopy. We really look forward to your participation, feedback, and joining us and helping us set future events as well, like this one. We, again, very much thank partners like AMBU for joining us in our mission and supporting us in our goals. And with that, I will hand it back over. Thank you so much.
Thank you, Dr. Sethi, for the opportunity. I'm honored now to introduce our first speaker, Dr. Shivangi Katari. Dr. Katari is an associate professor of medicine and the associate director of endoscopy at the University of Rochester Medical Center. Dr. Katari received her medical degree from Seth GC Medical College and KEM Hospital in Mumbai. She completed her internal medicine residency and GI fellowship training from Seton Hall University School of Health and Medical Sciences, and then later her interventional endoscopy training at Stanford University Hospital. Thank you, Dr. Katari.
Thank you, Hannah, and for that kind introduction. Thank you, Dr. Sethi, for inviting me, and thanks to Women in Endoscopy for inviting me to this real fun and important webinar. And thank you, AMBU, for supporting it. My topic is life beyond lockdown, a topic that will highlight the challenges that we faced and the importance of work-life balance in our current situation. So a few things that I will be highlighting today are our life pre-COVID and some issues that the pandemic brought into our lives, and why is work-life balance or integration so important, and why are we talking about it, and just a few tips and tricks that I know have worked for me in helping achieve a good integration of your work and your life. So in this day and age of do it all, we all know burnout is very common. As physicians, we are always trained to be available for our work, our patients. And there is a literature now showing that there is rising depression, dissatisfaction, and burnout in medicine. Compared to burnout surveys done in 2011 to a couple of years later, the report showed that there was more burnout in physicians, up to 54.4%, lesser satisfaction with work-life balance, and a higher positive depression screen. Coming to gastroenterologists, the ACG burnout survey conducted a few years ago showed about 49% of the gastroenterologists reported burnout, and women gastroenterologists were significantly more likely to identify themselves as burnt out. So what are some of the contributory factors that could be leading to this? And, I've just tried to touch up on a few. I'm sure there are a lot more that we deal with, but longer working hours, RVU pressures, increasing workload and patient volume, decreasing reimbursements, increasing imposition of external regulatory burdens such as electronic medical records, lack of adequate staff, dysfunctional workplace dynamics, lack of a team spirit and respect among colleagues, which I think goes a long way. Loss of control over the administration of your work environment, where you feel like you're not in control of your workplace, and you have a lot of bureaucracy to deal with. Student loans, debts, single income families, young families, all the surveys that I said showed that younger faculty or those with kids, or these were at a higher risk for reporting burnout. Having over expectation of yourself, if you're a type A personality and you want perfection in every last thing that you do, or you don't feel satisfied with the task you've completed, that can contribute to it. And your individual ambition and competition that you're dealing with can affect the drive and the burnout. Some of the issues that were unique with the pandemic, and we all went through a lockdown, those were unprecedented times, some things that none of us saw coming, and there was a complete disconnect from friends, family. There was no help or support, or anyone who can come. I know our nannies weren't coming, and when we were in the lockdown, kids were homeschooling. There was Zoom. My kids' Zoom meetings were on my phone, and my Zoom meetings were on my phone, and it was a very busy calendar. Planning their meals, kids barging into work meetings on Zoom. I've had that happen to me, despite chaining down the door. Longer work hours, hospital duties, extra calls, staff furloughs, pay cuts, all these things really stressed the system and the healthcare providers. Your own health or your family members' health being affected in the pandemic definitely put a big burden on everyone. Data showed that in a cross-sectional survey of physicians from 2 large hospitals reported that 68% of them reported burnout, and over 60% reported emotional exhaustion. 22% felt low personal accomplishments, and 21% either considered quitting the profession or had quit a position. And women were more likely to report emotional exhaustion and feeling of a low personal accomplishment. And in another qualitative study using interviews of over 90 healthcare providers, they did find that the mental health of the healthcare providers was deteriorating as they went through the pandemic, through the changes in their personal life, and working in the pandemic era. They faced anxiety, helplessness, depression, PTSD, burnout, and These were all emotions across all healthcare providers, and this was not just physicians. So, what does burnout do? It is not just this feeling of job dissatisfaction. As physicians, healthcare providers, it can lead to error rates, low patient satisfaction, depression, abuse, family issues, failed relationships, and of course, physician suicide has been reported to be on the rise. So this is where work-life integration comes into play. It is not just a hard balance. Everybody talks about work-life balance, which I feel has firmer borders. But work-life integration, and I think the pandemic really highlighted this, where your work and your home and everything just amalgamated, especially when we were working from home. Your community health, everything was kind of these balls that were all coming together. So I think work-life integration, simply put, is taking care of your personal tasks between your work breaks and vice versa, where there is this sprinkle of tasks in both the lives, and you're not drawing just a firm border between your work and your personal life. And in a recent survey of physicians younger than 35 years, 92% of the millennial physicians rated work-life balance as their priority. So we know the problem, and we know the problem has been highlighted by this pandemic. And question is, what are the solutions? And how do we look at our life beyond the lockdown? And I think the first thing is that you define your own success. One woman's floor is another woman's ceiling. Making the most of your time, prioritization, increasing efficiency, especially with our increased workloads, and always making time for self-care. And I will go through these individually to highlight the solutions. And the first thing is, defining your own success. I don't think comparing your definition of success with somebody else's may be completely different. So set your own goals, which you want to reach, whether it's a 5-year goal, 10-year goal, what you want in your career, what is your priority at that time. Pick a work environment that suits you. I saw a lot of physicians retire in the pandemic who were contemplating, and then just felt like this was time, and they now wanted to spend their more time with their kids or with their hobbies or golfing. So priorities do change, and whether you want to work full-time versus part-time, whether you want to be in private practice, academics, do what makes you feel happy. And I think that is really important, especially when you retire and you look back what you could have done differently. Start thinking about it, and do not stay in a toxic job environment. I think that is very important, that you like what you do, and you tailor how you want your work day to look like. Making the most of your time. So once you're at work, you want to maximize your output. You want to make sure your institution and your practice know that you're in it, you're dedicated with your work. And then you seek out that your practice or your institution or your employer supports you back when you need that support, and that it is a two-way street. Ask for help, and I cannot reiterate that enough. If you don't ask for it, you don't get it. So ask for the help, request your protected admin time or admin personnel who can make your life better. Protected time set aside for your admin tasks, and set aside time for non-work activities. So just like you're making time for work, you also want to carve out time for your activities outside of work, and learn to say no. We all have this thing of, okay, we'll do it and we're available, but take a sit back and say whether that thing is worth your time, efforts, whether you're, they're calling for a 7 p.m. meeting, which could easily be done by at 4 p.m. Ask for that. Can we change the meeting to 4 o'clock or within work hours, and minimize after hours meetings, and have a realistic expectation of yourself. It's never perfect. There is always somewhat the other ball up in the air, and be kind to yourself for that and to others. If you are in a leadership role, which I was during this pandemic for my unit, I was a part of the leadership team, and through the entire process of closing down the unit and then reopening up. And I think, when you are in a leadership role, you want to be mindful of the people that you work with. You want to, of course, have strong communications, but provide flexible work and space for your employees. If they have kids at home or elder care at home, parents at home, and they need a little flexible time, or you give them the ability to work from home, or the setup that they need to give their best while they are working from home, and that will provide a supportive work environment. It will create a stronger team, and help recognize burnout. If provide help, reach out. If you see someone stressed out, talk about it, or even a kind word, I think, goes a long way. A little posted thank you to your admin team or secretary, or just getting them coffee, I think goes a long way in them supporting you, that Dr. Kothari, what can I do for you? So I think it is very important that when you want to make the most of your time and help your team give their best to it. Prioritize, and this little grid kind of puts things into perspective, where you things that are urgent and important for you versus things that are important but you can put them a little bit on the side burner, versus the things that are need your immediate attention, whether they're some deadlines you're working on, your clinical responsibilities, emergencies, whether it is health related, family, whatever it is. At that point, that things takes precedence. And things that can take a little sit back, your administrative task, a paper that you have a few days to finish, or you keep working on it every day, and not till the last deadline and the night before you're trying to pull an all-nighter. Producing more time in the same amount of more work in the same amount of time, and increasing your efficiency. And a big part of this, I think, is having good mentorship, learning from other people's experiences, people who are either senior to you or even colleagues. You can have mentors at work, you can have mentors outside of work, and it doesn't have to be from the same institution. I have friends of my like my kids' friends' moms who keep me in tune with what's happening at school, what I need to get, and that's my social mentor. So it's I think it all around helps your life run a little bit smoother. Now with the pandemic, there are Zoom meetings, there are webinars being offered, there is a lot of online learning. Attend webinars and meetings that you think are helpful for you, and just like this one. And make sure that you prioritize which ones that you want to attend, and what will give you a take home and is going to help either your clinical or your non-clinical life. Multitask, meal planning apps can be helpful. If you have kids that are homeschooling, create a plan and a routine, so there is not chaos ensuing in the home in the morning. And outsource and delegate, whether it is hiring an assistant at work, or you just want to do a dinner takeout to get a break from cooking. Any kind of delegation and outsourcing, whether it's work or non-work related, will definitely help you focus on the task at hand, or help you become more efficient and give your time to things that are more meaningful for you. And with all those, organizations, we definitely stood by its members throughout the pandemic. And even now, as Dr. Sathi said, it's a global organization that champion the advancement of women through educational growth and leadership development. They had a great webinar series for the fellows for non-clinical topics, clinical topics. It is a great avenue for networking, collaborations, mentorship. They also have job postings, and it also touches on leadership and wellness. And these are pictures from our yoga sessions that were held as a part of a V session at ACG in 2019. And the other picture is from the retreat of the V leadership. So coming to self-care, it's not just about your your physical health. It is also your mental health and your overall wellness, which is very important. So I know with the pandemic, and the gyms were closed, and I think a lot of people got either home exercise machines or online. There were so many yoga classes or Zumba classes happening. I know a lot of gyms were offering online sessions, and I think that definitely helped people keep in sync with the rest of the community, and also keep your health in check. So I think and also when you exercise, you do feel good about yourself. So try to carve that out into your schedule, whether you want to bike to work, or you want to work out before or after work. But I think physical activity definitely will go a long way in terms of your self-care. Mental health, as I said, be kind to yourself. You missed a deadline, or you forgot to do something, and make sure that you understand that you're not alone in this. There are millions of women that are facing these challenges, and we are all in it together. And the key is that the person next to you may be going through the crisis themselves, so reach out to them. Make sure to make time for your own health, well visits, and identify any stressors that you can think of, and anything that you can think is solvable. Make time for your extracurricular activities, whether it's hobbies, you want to take up music, reading, dancing. I took up dancing after I had my second child, and I think I really enjoy it. Make sure to take vacations, and disconnect when you are on vacation. Try to avoid checking the emails. Use your allocated vacation time. If you in the pandemic, I used to hike a lot. You want to be outdoors, and you don't want to be in a closed space. But the key is to disconnect and get that time for rejuvenation, and do one thing for fun. I think that's non-technology related. I usually every day play a board game with my kids, and I think I really enjoy doing that, and that's our time at the end of the day to connect. Make time for your family, friends, community. Be present for your relationships, whether it's your kids, your parents, your pets. Even if you're tired, make that time to socialize, have the girls' night out, get connected with the community if there is any interest group you want to be a part of. And when you are with your family or your friends, disconnect from the work, and focus on having the fun times that you're out for. If you're planning a family, there's never a perfect time. Timing is what works for your family and you. Make sure you know your institution's FMLA, and you've looked at that, reviewed that, and take care of your needs first. Even the airlines tell you that in case of an emergency, first put your oxygen mask, and then you'll be able to help the person sitting next to you. So those date nights, spa days are very important, and reward yourself when you do it. How I do it, I know that I definitely can't do it all, and it surely takes a village. And as I said, I was part of the leadership team during COVID, and I actually, Dr. Sati knows, I used to text and call her for guidance for what I can do in my unit to help my unit. I did learn to say no, and we try not to talk shop at home. And I did seek support from my family, work. If I'm in a meeting, my husband's holding fort and vice versa. And definitely made time, as I said, for my hobbies. And I did pick up dancing and exercise. So in conclusion, the key is recognize burnout early, ask for help. It is not just a problem of the women, but definitely more prevalent in women. Aim to work for the work-life integration and balance that works for you. It is attainable certain days more so than not, but the key is that you aim for what works for you and your family, and love and integrate your work and life, and pay it forward. If you feel you're in a happy place, try to share it with your team and the people around you, and support your peers. These are some of the resources. So during COVID, there is a physician support line that was created with over 700 psychiatrists who were there to support the physicians. And these are some personal reads that you can look into, but these are some resources that can help you on to help with any burnout or any odd feelings that you may have. So thank you very much for listening, and we'll hand it over.
Thank you, Dr. Katari. Some very poignant points, I think, for everyone on the line in many ways. So with that, I'd like to introduce our next speaker. I want to remind everyone there is a Q&A feature down at the bottom of your screen where you're welcome to submit questions at any time or in the chat box. And then we'll have that moderated session here after our next presentation. So Dr. Rabia De La Torre will be leading the next section. Dr. De La Torre is a double board certified GI and therapeutic endoscopist in New York City. She is an assistant professor of medicine at NYU School of Medicine, the director of endoscopy at Bellevue Hospital Center, and associate program director for the NYU GI Fellowship Program. Thank you, Dr. De La Torre. The floor is yours.
Okay, great. Hi, my name is Rabia De La Torre. Thank you for that lovely introduction. I'd also like to thank Dr. Sethi, not only for founding this wonderful organization, but also for inviting me here to speak today. And I'd like to thank WIE for having me as well, and Dr. Katari for a wonderful talk that was really, really helpful. All right, so today we're going to be talking about ergonomics and endoscopy. A few things that we're going to talk about today are just the meaning of ergonomics and its importance, risk factors for endoscopy related injury, types of injury, injury prevention, and just ways that you can overall be a better ergonomically friendly human being. So what exactly is ergonomics? It's a science of designing tasks to fit within the physical and cognitive capabilities and limitations of the breadth of users. It actually is from the Greek ergon, which means to work, and nomos, meaning laws. And it's basically defined as a science of fitting your workplace to your needs as a user. And the aim is to basically increase efficiency, productivity, and reduce comfort by any means necessary. So why does it matter? In reality, how frequent are these injuries? Do we actually know? And this actually has been studied. So in 2009 at UCSF, a systematic review of multiple studies, about 7 was done, looking at the rates of endoscopy-related musculoskeletal injury, and they reported a very wide range of 37 to 89% prevalence of injury among endoscopists, and most of this was based on survey data. Because the majority of this data has been published over the last decade plus, like decade and a half, it's become a bit of a trending topic, and it really begs the question of why we've ignored this for so long. In subsequent publications, the writer of that actual paper, Dr. Shergill and colleagues from UCSF, brought up some really excellent points about ergonomics. Basically, why have we made such significant advancements in our scopes and the optics of our scopes, even to a point where we may have AI detecting polyps for us, but the actual physical scope has not changed in the last several decades. She likens it to buying a great new luxury vehicle, but not being able to adjust the seat for your size or for your height, and having essentially a one size fits all policy, which is really what our scopes are, if you really think about it. And she also goes so far as to say we really wouldn't accept this for our cars. So then why are we accepting it ergonomically for our scopes? And that's a really, really great question. And so if the world's most famous athletes these days, like Serena Williams, Tom Brady, and Roger Federer, are basically creating longevity through conditioning and exceeding previously defined limits of age on their longevity, it's really up to us to learn and optimize our ergonomic education and foster good habits and practices and really break the previously accepted terms of our tenure. And not only that, but really propagate this and educate other people who we are training, as it is our responsibility if we work in an academic center. All right, so what is this? This is the hierarchy of controls. It's used by OSHA and to outline risk mitigation strategies in any field, but it is applicable to endoscopy as well. And what it serves to do is provide a hierarchy of effectiveness for potential interventions. The most effective changes you can make are at the top, like elimination and substitution. The least effective are at the bottom, like administrative controls and PPE. When it comes to improving ergonomics in endoscopy, Dr. Shergill and colleagues highlighted this hierarchy of controls that has been discussed in nearly all conversations about ergonomics because it represents an organized manner in which to think about affecting change. So at the top, you have the options of elimination and substitution, as you can see on this chart. You can either eliminate the scopes you're using or find a substitution. So obviously in 2021, we can't really eliminate the scopes. That's not really an option for us, but we can definitely start thinking about substitutions, particularly when working with device companies like Ambu, for example, who can ideally create and manufacture alternative solutions to the currently utilized one-size-fits-all scope. There are self-driving scopes that exist, like the Invendo, that are still in development, and several companies, including Ambu, have developed disposable duodenoscopes meant to prevent elevator-associated infections. And this is really a golden opportunity for industry to create different size options and accommodate those of us with different ergonomic needs compared to people that the standard scope was created for, which is typically men with larger hands, if we're being honest. So moving down the list, you have engineering controls, administrative controls, and PPE. For engineering controls, which in endoscopy translates to optimizing your endoscopy suite and the scope itself, which we're going to go into further detail on later in this talk. You also have administrative controls, which translates to promoting a culture of talking about ergonomics and keeping it as a priority and focus. And lastly, PPE, which is basically altering your endoscopist technique, making sure they're taking stretches and breaks in between endoscopy or even during endoscopy and maintaining their physical fitness, which is very important. All right, so let's talk about the different types of injury. You have hand and wrist injuries, which are probably the most common. You have neck, back, feet, and also shoulder injuries. You can also have injuries that are related to repetitive strain, meaning you've over-exercised or strained your hand in a certain way over and over and over again to the point where you're starting to have aching and pain, and it may kind of have some point where you can no longer scope, or an acute injury, meaning you're doing ERCP and you press that elevator just too hard that one time and it causes, a tendon rupture or damage or strain. And that's something that you acutely feel suddenly and may or may not require surgery for, which I've actually been a witness to in a room as a fellow when I was the advanced endoscopy fellow. So it's not a pretty sight to see that. So in the hand and forearm, you can, of course, have left-sided injuries and right-sided injuries as our two hands are performing markedly different tasks. On the left, you can develop de Quervain's tenosynovitis from manipulating the dials of the colonoscope due to strain or injury of the left abductor pulsus longus. I promise I won't go through too much detail of these muscles because I know that no one's going to remember them, and I probably won't remember them after giving this talk, but I'm trying to remember from medical school, my anatomy lesson. But you can also develop tennis elbow from having to stabilize the control section or the head of the scope due to excessive wrist extension and abduction. That's on, again, the left hand. You can also develop carpal tunnel syndrome from grasping the control section or the head of the scope where all the dials are due to strain of the left flexor digitorum superficialis. Say that 10 times fast. On the right side, you can get similar injuries of the ECR and FDS from having to torque and grasp the scope, especially if you're not doing it correctly. And we're going to go into details about how to do it properly to prevent these injuries. Neck injuries include cervical neck injuries due to overextension and flexion or rotation, especially if your screen is not situated properly in your room, whether it's too high or too low, if you're turning your head side to side to look at, let's say, your endoscopy screen and your fluoro screen. And we'll talk about how to optimize those for yourself. In terms of back injuries, you can also develop lumbosacral injury due to prolonged standing and also patient positioning. If you're really kind of getting in there and helping your staff move the patient, you can overextend yourself if you're not careful, if you're lifting mostly with your back. In the foot, you can get plantar fasciitis, arthritis of your ankles, especially if you're not wearing some shoes with cushions. I've been guilty of this where, you had a meeting and you're wearing dress shoes and then you don't have time. And pre-COVID, I used to scope in them all the time, which I really regret. I should have never done that. But now with COVID, if we're going to look at any silver lining, it's that most meetings are on Zoom and you can still get away with wearing sneakers to endoscopy. So we're trying to see the positive in all of this. In terms of shoulder injuries, you have frozen shoulder, rotator cuff injuries, and impingement as well. And here's just a picture of those muscles in case you're interested in reviewing your anatomy from medical school. All right, in terms of risk factors for injury, you have just performing endoscopy itself as a risk factor. This seems pretty intuitive, but studies from the Mayo Clinic and the AGA Women's Committee survey evaluated the risk of musculoskeletal injuries among endoscopists versus non-endoscopists, and also the rates of injury among women after they started endoscopy after training, and they all displayed a doubling or more than doubling of the rates of injury when performing endoscopy as a part of your career. And this makes a lot of sense because endoscopy is a very physical thing to do, and you can have injury as a result of it, especially if you're doing it for years and years and years repetitively, and especially if your technique in terms of ergonomics is not correct, you can really hurt yourself. I think one of the most salient takeaway points from these studies for me personally was that after these people suffered injuries, less than 5% were then subsequently educated and trained on proper endoscopic methods to prevent future injury. So think about someone who might have had a hand injury, and then ask yourself if they actually got some formal training subsequently to make sure that they didn't do the same thing again. A lot of times we kind of assume that it's at the fault of the endoscopist, like, oh, they must have just push themselves too hard or something, but actually going through the motions of training them and making sure that they don't make that mistake again, and they don't teach similar mistakes to their trainees if they're working with fellows, is so extremely important, and I cannot stress that enough. Personal risk factors as related to the endoscopist include poor posture, specifically what's called non-neutral positioning of your body. This is actually the leading cause of back injury, as we tend to bend forward, especially if the table is too low. And this can increase your lumbar spine compression by up to 50%, which is huge, just by bending forward too much while you're scoping. Neutral postures are defined as a resting position of each joint, meaning you're not putting stress on anywhere in your body. You're just kind of like loosey-goosey, right? Standing not in a neutral position. Non-neutral postures are basically gaining the same effect, but using much more effort and strain. So you're basically getting the same benefit, but just really hurting yourself in the process. So it's really important to maintain neutral postures and neutral positioning. High forces in pushing and pulling the scope, especially when they're associated with non-neutral postures, can really increase your risk for musculoskeletal injury. High-risk mechanical pinching of the dials in the scope can also contribute, and I'm going to go into how we can prevent doing that. Unnecessary non-neutral flexion or extension of your wrist can also decrease your hand grip strength significantly. And this has been studied where you extend or flex your wrist too much, you're decreasing your ability and your grip strength by almost half. So it's really important to maintain a neutral wrist position as well if you can. And in reality, gender is likely to play a role. I'm going to talk about a study in a little bit that showed that, men and women had similar incidents of risk, but I think even though the survey data available to us has not repeatedly shown that women are at higher risk, I think that they are, because hand injuries are so common and women on average do have smaller hands. So at the end of the day, given the fact that they do have smaller hands, they're more likely to have injury. So that's really important to know. All right. So before I go into the study, actually, I want to talk about one more thing. In one study of gastroenterology fellows, individuals with a hand size that was less than 6.5, mostly of whom were women, they felt that the endoscope was too large for their hands, and this impeded their ability to learn endoscopy. And as someone who teaches fellows to scope, I hear this every single year, and I'm sure you guys do as well. I can't reach the button to take a picture. I can't reach, the small dial with my thumb. It's too hard. And it's a reality. When you have a one-size-fits-all endoscope, there are people whose hands are too small to actually reach the things that they need to reach, because these scopes were made for people with bigger hands. And that's the reality that we need to accept and work with. Suboptimal grip of the scope can result in a decreased ability to produce force, like I mentioned, and basically exact those necessary and effective maneuvers. Power grip is optimal in the neutral position, and any deviation from this neutral position in the hand muscles, maximizing their voluntary contraction, will result in a decreased ability to produce force, like I mentioned. And then lastly, you have environmental factors that include repetition of procedures without breaks, especially the percentage of time you spend performing endoscopy in the volume, and also the one-size-fits-all scope, which I'll just keep on mentioning over and over again. A 2015 ASGE survey found that most gastroenterologists are now spending over 40% of their time doing endoscopy, whereas 20 years ago, this was less than 40%. And so naturally, the more you scope, the more likely you are to have musculoskeletal injuries that are associated with scoping, especially if your technique is off. All right, so I'm going to now talk about the study I was mentioning. So this is a really wonderful study that was published in the American Journal of Gastroenterology earlier this year. And Dr. Kothari, my esteemed co-speaker, was an author on this study. And so it's a really great read if you haven't already read it. So this was a survey study including nearly 1,700 patients, and they aimed to assess the prevalence of self-reported endoscopic related injury, patterns of injury, and also the endoscopist knowledge of preventative strategies. So a lot of what I was talking about, they aimed to study in this study from earlier this year. They found that a whopping 75% of the people who responded to the survey reported some degree of endoscopy related injury, and that men and women had similar rates of injury in the people who responded to the survey. Women were more likely to suffer from upper extremity and upper back injuries, and this was attributed to non-adjustable beds and monitors that they couldn't move and torquing of the scope with the right hand. Men were more likely to suffer from lower back injuries, and this was attributed to the weight of lead aprons, which as we know can be very heavy, and the use of the elevator with the duodenoscope, which can place a lot of stress on the left thumb. In the multivariate analysis, they found that both the number of years performing endoscopy and the hours per week were independently associated with endoscopy-related injury, and the most respondents did not discuss ergonomic strategies at their current practice, about 63%, which is quite a large number. Also, endoscopic-related injury was less likely to be reported in GIs who took a break during endoscopy, and that was statistically significant. So very important that small intervention can actually help you reduce the injury rate. So that's very good to know. The free and easy intervention, and it's nice, always nice to take a break, isn't it? So let's talk about lead-related injuries. So if you do any fluoroscopic procedures, whether it's different types of dilations, ERCP, interventional EUS that requires fluoro, you're going to be wearing lead. Lead aprons can weigh up to 20 pounds, and one piece lead apron can apply up to 300 pounds load per square inch to the intervertebral discs. That's huge. So a potential solution can be to wear a two-piece lead suit with separate skirt and shirt, which can help to distribute the weight to the hips. And this will lead to less neck and back discomfort. And this can reduce the weight on the lower back by up to 80%. So it's very important. Moreover, it's also really important to place, like I mentioned earlier, your fluoro and endoscopy monitors next to each other so you're not constantly turning your neck. I have to admit, when I started, I was guilty of this. We had our C-arm in one spot and then the fluoro monitor in one corner and the endoscopy monitor in the other. And so I was constantly moving my neck back and forth. But once I started researching better ergonomic practices, we moved it. So it's very important to make sure that you have those screens next to each other, because you're preventing a neck injury in yourself and also your staff who are looking at these screens with you as they assist you during the procedures. All right. In terms of prevention, there's personal modifiable interventions and there's also room interventions. So what are some ways that we can prevent all these horrid injuries I've described to you guys? Personal interventions that you can start practicing really at your next endoscopy session, maybe tomorrow morning even, are to maintain a neutral position of your body while scoping, and also of your extremities, meaning your wrist, your thumb, your hands, your arms, your legs as well, and making sure that you maintain the same amount of weight on both feet. You're not like kind of balancing on one foot or the other. When you're standing to scope, you have to have your feet shoulder width apart, and this is called the athlete stance. And this is highly recommended in all the ergonomic literature to make sure you can prevent injury. I'm going to review detailed techniques for hands on the scope shortly, but you can also practice strengthening stretches for your hand and body, including squeezing stretches for your hand and back and neck stretches. A lot of the literature recommends that you roll your shoulders, and they say you should do this while you're washing your hands over and over again. Maybe they just want to promote, cleanliness and good hygiene, which is funny, but like you can roll your shoulders whenever you want, but it's good to do it. Remember to do it, whenever you're washing your hands, if that's something that you might forget yourself. It's also totally acceptable to take a pause, like I mentioned, mid-procedure. Give your back, your hands, your legs, everything a break. Stretch your legs out mid-procedure. Take a pause if you really need to, especially if it's a case that is stressing your body out. So it's really important to do. In terms of room interventions, you should make sure that your monitor position is at eye level, and I'll talk about that in exact detail about where exactly you should have it. The bed height should be really at between your elbow and your wrist, the top of the bed, or where you're going to insert the scope. You should have short, straight, and soft scope orientation. And consider a cushion mat. Consider cushion mats for all of the rooms in your endoscopy unit. If you're someone who is in a position to order these, they've been found in studies to basically subjectively reduce the amount of strain on the legs. And it's just a good thing to do, especially if someone doesn't have cushion shoes. It's really nice to have a cushion mat to help them. All right, so in terms of the actual detail of how to set your room up properly, one, you want to position the monitor in front of you at a height of exactly 93 to 162 centimeters, depending on your height. So it should not be in a position where you have to really turn your neck up, down, side to see your monitor. It should be really right in front of you across the bed. And for fluoroscopy cases, like I mentioned, the fluoro image and the screen should really be next to each other to prevent the amount of turning that you have to do. The viewing angle of the screen should be 15 to 25 degrees below your eye level. So you should be looking straight at the screen with about 25-degree maximal amount of view below your eye level. So that's very important to know. Lastly, the monitor should not be too close to your face. You want to have at least 52 to 182 centimeters between your body and the screen, because if it's too close, it can cause eye fatigue, dizziness, headache. Just like if you're looking at a computer screen all day, you need some distance between your eyes and the screen just for your eye health as well. So having it on the other side of the bed usually takes care of that situation. If you are wearing glasses, if you're someone who has bifocals, this is not really recommended during endoscopy because it causes you to have to actually extend your neck a lot to see out of the bottom half of the glasses usually. In terms of bed height, adjust the table to where the colonoscope shaft is held between the elbow height and about 10 centimeters below the elbow. So roughly that's between your elbow and your wrist. If you're not sure, if you don't have a measuring tape with you at all times. And in terms of your unit, like I mentioned, get some cushion mats as is shown in this photo, because that can be really helpful for your team. Next slide. All right, so in terms of room setup, there are 3 different room configurations that we're all familiar with. You have the endoscopist centered room setup where the processor is behind the endoscopist and the patient is obviously in front of them. There's the system centered setup where the processor is to the right of the endoscopist. And then there's the bed centered setup. And that's where the processor is right in front of the endoscopist on the other side of the bed. And that's usually what we see for bedside cases in the ICU where we don't have our optimal setup. So if you were to guess which one is the best, I'm only going to give you guys 2 seconds to guess. Yes, you're right. It's the endoscopist centered setup. And the worst one, like I mentioned, is the bed centered setup. The endoscopist centered setup on your left offers the most ergonomically favored setup with the highest amount of maneuverability of the endoscope, access to the patient's airway in case there's emergency, and the best setup for the staff as well. The bed centered setup is the least favorite setup. We're essentially scoping over the bed, and we use this, like I mentioned, in ICU cases. So what I do for bedside cases is I've actually started asking them for an extra monitor, because the people who set up our scopes, like it takes a little bit of extra effort, but it makes a world's difference. So I'm not like scoping, for an EGD and looking at the screen over my shoulder if the cart is behind me. And I really just like scoping over the bed. So I try to do whatever I can to ergonomically set up these bedside cases. It takes a little bit more effort, but it's so worth it, especially have these long ICU cases, which tend to be severe bleeders who are very sick and you don't know how long you're going to be in there. And, especially if you're training fellows, it's important to teach them that we shouldn't be, cutting corners even when we're doing bedside cases. It's better for you, and in turn, it's better for the patient and patient safety if you're more comfortable. So that's very important to note. All right, so how about your right hand? What should you be doing with that? So the best way to actually hold your scope is like a violin bow, not like a tennis grip. And that's very important to know, because as we train fellows in July and August, we see a lot of people grabbing the scope like very tightly as if it's going to fly out of the colon if they let go. So it's really important to hold it like a violin bow, as is seen in photo C right here. This is a preferred way to keep a more neutral position of your hand. Like I mentioned, when you grab it like a tennis racket, you're exerting a lot more force, like I mentioned, for the same exact effect, and that's a non-neutral position. So you can cause not only finger and wrist, but also elbow injury. In picture A, you can see the scope acting as a lever to reduce right hand torquing. So that's really important to know. You shouldn't be holding it right at, if you're doing a colonoscopy, you shouldn't be holding it right at the anal verge. You should have a little bit of space so that you have more ability to torque. B displays a neutral thumb grip position. Photo C is a reminder to make sure you use really good high friction gauze. I find that to be extremely helpful, especially when there's lubricant on the scope. Lately we got a batch of gauze that just had less friction, and I was like, no, we need the good gauze. So do that for yourself and ask your staff to help you out if there's something that is better for you ergonomically. There's nothing wrong with asking and making sure that the situation is optimal for you. And then lastly, in D, you can see the left hand pinky grip technique, and that's used to reduce right hand strain, which can be used in difficult or tight endoscope positions, contrary to the teaching that you should never, ever, ever use your right hand to grab the dials. I see that taught a lot. And the way I teach our fellows is there are cases where you absolutely have to use your right hand, and that's okay because your left hand just can't handle whatever, like the multiple things it's being asked to do. So I'm not saying like make a habit of it and do it every time, but it's okay to do it in certain situations. So it's not completely wrong. All right, so I want you guys to take a minute and ask yourself, when you're holding your scope, is the actual what's called the universal cord, which I don't know if you can see my mouse, but this part right here, do you put it on the inside of your wrist or the outside? I had to think about this when I was first asked because I wasn't sure. I didn't actually remember. And if you were to guess which one's better, now obviously my picture is kind of giving it away, but you have to basically run it along the inside of your forearm or wrist. And think of it as like you're holding like a necklace that's basically draped around just your thumb being held up. That's the ideal way to hold it. And that is because you're alleviating some of the weight of the scope on your forearm as opposed to letting it hang. Because letting it hang on the other side of your arm on the outside basically means that your hand is not only holding the control center or the head of the scope, but also then having to lift some of the scope up. Let your forearm do some of the work for you and essentially make sure that it's on the inside. Right there, running along the inside of your forearm. That's a very important intervention in terms of holding the scope. All right, in terms of scope orientation, you want a short, straight, and soft scope orientation, like I mentioned, that's maximally responsive to the tip deflection and torque of your scope. And this will minimize the amount of force required to perform any endoscopy. For upper endoscopy, you really want that control section to be more upright, and while you're performing a colonoscopy, it's held more at a 45-degree angle. And the thing is, I won't say that before I start every procedure, I'm like thinking to myself, am I at 40 degrees? It just comes naturally to you. But I think for those of us who are teaching endoscopy, it's like a good thing to kind of recognize when you're watching someone else scope that you ensure they're not holding it the wrong way, because it can cause them to be uncomfortable and they may not want to complain that this hurts because they're new. And so it's just important for teaching endoscopy, I think. All right, so some of you may have heard of this all fingers technique. I previously had never heard of this until I started learning more about ergonomics. Deemed by some to be the most effective way to manage scope control body, which is the head of the scope where all the dials are. I have to say this advice is definitely predicated on the idea that your hand can actually fit around the entire scope, which not everyone's can. But the gist of it is the idea that each finger, except for the pinky, is really doing at least 2 jobs. So you have to use your thumb to move the big dial a lot. And there's going to be times when, as you can see in this photo, you may have to move it, but then you need your thumb to take a photo or press one of the rear buttons. And this comes intuitively to most, but you can use your index and middle finger to actually hold the big wheel in place. So you're actually utilizing it to do that job for you while your thumb is doing something else. And this allows you to basically hold the dials in place. Let's say if you're in a really tough position, not only is your big wheel maximally turned and your small wheel is maximally turned, and you don't feel like locking your wheels necessarily, or maybe you have locked your wheels and they're still kind of drifting back to neutral position, because that's what the scopes do. There's a spring to make them go back and coil back into neutral position. So if you use your fingers right here to basically help you maintain the position of those wheels, that's called all fingers technique. And it can actually help alleviate thumb strain over time and prevent thumb injury, which again, we all know is pretty common in endoscopy. All right, so we briefly mentioned hand size a few times in this talk, but since we're at a women in endoscopy event and women on average have smaller hand size, I felt it deserved to be discussed just a little bit more. So on the left, you can see an individual with a 6.0 size glove holding an Olympus 190 scope. And on the right, you can see that the same scope being held by someone with a size 7.5 size glove. So you can clearly see the difference in the ability to grip not only the scope itself, the scope head, the control center. But you can also see that the person on the right is going to have an easier time with the all hands technique that I described to you than the person on the left. So this is just another reason why this one size fits all scope situation is not ideal. And I hope that in the next, few decades, we see a change in that. We should be able to have, oh, get me this size scope and get me that size scope for my hand, instead of all being forced to use that. So your next question might be, since we don't have those different size scopes, what can I do if I have small hands? So are you banished to a land of, inevitable hand injuries? No, there's things you can do, not only the ergonomic things I taught you today, but also you can focus on building your hand strength through conditioning and exercises and, doing squeeze exercises. But you can also buy this device called the Olympus Dial Assist. So this is actually something that I have a bunch lying around in the endoscopy unit. They basically make the small wheel bigger so it's easier to reach, especially if you have really small hands. I give them to a lot of our fellows and staff, but it's usually women who ask for them. I've never had a male fellow ask me for one or a male attending, but people with smaller hands tend to benefit from this. And the best thing about it is it's not producing a ton of waste. You can autoclave it and just give it to the people who clean your scopes, and then you can reuse it. So it's actually a pretty nice device to have, in case you need it, especially if you're having some thumb pain. All right, so let's take a step further and discuss some additional preventative measures we can take with sign-on from your department, definitely. So if you really want to elevate your whole group's ergonomics game, you can arrange for individual PT sessions for each endoscopist in your unit and offer them a sort of like personal training physical therapy session that will allow for a PT to come and evaluate their endoscopic behaviors and improve them in order to prevent long-term injury. Arranging for such sessions could potentially promote career longevity, reduce work-related injuries and missed days of work, as well as quality of life. So I think it's something to consider, especially if you don't have a humongous department and your hospital is willing to pay for it. 2021 study in GIE that was actually piloted and spearheaded by a physical therapist did just this. They aim to develop a new method to assess endoscopic wellness and also the ergonomics quality of the endoscopist. So this physical therapist observed 8 endoscopists during 2 colonoscopy procedures, and then also like peri-procedure when they were doing work at their computer and other things, just like kind of, preparing for their procedures. This was followed by an assessment of their most frequent pain sites, ergonomic insufficiencies, and suboptimal movement patterns. So the PT then created an individualized, like curated advice sheet with a plan of exercises, posture, re-education, optimal procedures, suite setup, and pain education for these 8 endoscopists. And they found that 63% of the 22 identified pain sites were reduced in intensity or resolved after this intervention. And 7 of the 8 participants found pictures depicting their posture supporting movement analysis very helpful. So it's something to consider, especially if you have a smaller department and the people in your group are interested and you have buy-in from your department to pay for it and a physical therapist willing to help you, it could be really beneficial. All right. So as we all know, pregnancy carries with it a slew of ergonomic risks on its own, and especially with endoscopy, if you were scoping while pregnant. I've done it twice, and I have to say it was like physically more taxing closer to the end of the pregnancy for sure, especially if you're wearing lead. And full disclosure, I did do some fluoro while pregnant. Please don't judge me, but I was very safe with it. So it is possible. Risks during pregnancy include an increased risk of carpal tunnel syndrome, lower back and pelvic pain, and also syncope, which can happen if you're standing for long periods of time and you have venous pooling in your legs. So for carpal tunnel syndrome, ways to prevent it are stretching, exercise, and also wrist splint support. For lower back and pelvic pain, you can make sure that your bed height is appropriately elevated, avoid heavy lifting. You can consider support belts or back braces, but I imagine that might be challenging, especially as your abdomen grows larger. You might not be able to fit a back brace around without additional discomfort. You can also consider sitting stool with a backrest while scoping, and a footstool to alternate leg raises. That's also a consideration. In terms of preventing syncope, you can wear compression stockings, which I admit I wear compression stockings every single day that I scope. I've been doing it since medical school when one of the nurses pulled me aside and gave me that advice. And I found it to be really helpful. You can avoid prolonged standing when you're pregnant and scoping, and also decrease your room temperature, because if it's really hot, that can really be challenging. And then make sure you're maintaining hydration. Okay, and then last but not least, we are not the only ones in the room who have ergonomic challenges. It's really important to recognize that your staff can get injured as well, especially if you're asking them to apply manual pressure and move patients for you. So it's just something to really consider and make sure that they are also maintaining good ergonomic practices. This picture is actually from a company called ColoWrap, and they have an abdominal binder that they sell for very obese patients who, or not even very obese patients, patients with large abdominal girth, and you're worried that you may not want to have your staff apply pressure. We used this during COVID when we were trying to minimize the exposure of our techs to patients unless it was absolutely necessary. So it's just something to consider, because there's a whole slew of injuries that endoscopy staff are at risk for as well. All right, so I'm just winding up my talk now. Sorry, I talk a lot. Takeaway points, just learn about ergonomics and teach about it at your institution. It's really important, like I mentioned multiple times, if you're teaching fellows, to make sure that they have safe practices, because that's essentially your legacy, and that's how the people you teach will remember how you taught them. Practice safe endoscopy practices yourself. It's a preventative health measure, and protect yourself, and be like Serena Williams and just play tennis forever. So that's my goal. Optimize your suite, like I mentioned, and remember that an injury is not your fault. You may have not been taught good ergonomic practices, and so you're really not to blame. Additionally, if you have very tiny hands and you're being asked to use this monster size scope, it's really, really not your fault if you develop an injury because of overextension of your hands. And so that's something to remember. I would get additional disability insurance if your hospital doesn't offer you a good package, because you never know when you're going to get injured. And it's just a little plug for disability insurance. I have it, and I find it gives me peace of mind. And then, continue ongoing discussions with industry to develop more scope options. I really hope that this is in our future and in my lifetime. So that is pretty much it. And then just another plug, if you haven't already joined WIE, it's an awesome organization. I, feel like I've met so many inspirational women, like the people on this panel today, that I look up to and have taught me so much through WIE. So I really highly recommend joining. Thank you so much.
Thank you, Dr. De La Torre. I think some very clear call to action for industry. Appreciate your talk very much. Now we'll be moving on to the moderated discussion portion of the webinar. Remember, you can submit your questions in the Q&A or chat box at any time. We are going to plan to go over by about 15 minutes in order to accommodate the moderated discussion. Joining Dr. Sethi from earlier as one of our moderators is Dr. Unji Shen. Dr. Shen is an associate professor of medicine at Johns Hopkins University. She is the associate director of safety and quality for the Division of GI. Dr. Shen graduated summa cum laude from Harvard University with a Bachelor of Arts in Biology and received her medical degree from Duke and her PhD from Johns Hopkins Bloomberg School of Public Health. Dr. Shen completed her internal medicine residency, GI fellowship, and advanced therapeutic endoscopy fellowship at Johns Hopkins. Thank you, and welcome, Dr. Shen and Dr. Sethi, and I'll let you kick off our discussion.
All right, thank you, both Shivangi and Rabia for great talks. And there's actually a couple really good questions in the Q&A box. The first question is for Shivangi. Is the stigma against mental health changing within the medical field? Is it generational? And what steps in the near term can healthcare systems take to make quality of life better for physicians?
So I don't think there is a stigma around mental health anymore. I think more and more physicians are talking about it, and I think as they should, because it does impact, as I said, your overall life. So I don't think it's just generational, but I think yes, the newer younger physicians are more aware about it, and they do know what they want in their life, which I think is nice. And sometimes I learn from my fellows and my junior faculty, and it is important that we are talking about this and we are aware about it, So before it snowballs into this big thing that leads to any bad outcomes, you realize if you feel like you're overworked, seek help. Every institution has helplines. Reach out to your your chief or your friends and talk about it. And as I said, I mean, especially with the pandemic, everybody's life changed, and they had these helplines that I put at the end of my talk for available for physicians by psychiatrists who were just there to listen and talk and support their peers working hard through this pandemic. So I think it is important to recognize it and report it and seek help. And I don't think there is any taboo to that.
Thanks. And I would add that, there are some facilities, for example, our ICU had early on incorporated psychiatrists or counselors into their teams of providers, not only for patients, but for the team members themselves. And I think that's something that will carry forward going through because of the recognition of not only the trauma that COVID created, but also that physician burnout, which was recognized much earlier than COVID has. Robbie, I'm going to ask you a question about ergonomics and training. I think there's a lot of emphasis now on incorporating training, ergonomics into training, particularly for fellows. But one thing that I think is difficult, particularly now that we have more women trainers, which is fantastic. We're getting more women, particularly in interventional endoscopy. How do you balance between the ergonomic needs of the trainer and the trainee, especially for advanced procedures where both individuals are controlling the scopes and everything that you mentioned is important for everyone. How do you sort of balance that? Do you have any tips from you and Shivangi as well, from you and Ananji? You're all trainers.
That's such a great question. And I have like a great relationship with like our advanced fellows. And I just remember one fellow who just would always like lift the bed like so high. And I'd be like, do you think you're running this room or am I running this room? Who's the boss here? And I just would let it go and like let him do that. But ultimately, I think what you need to do is find a happy medium between, let's say if you have a very tall fellow, and like I said, I've been in this situation. If there was a portion of the procedure where I was going to have him start and do as much as possible, or her, if you have a tall female fellow as well, then you can basically set up the room for them. But if it becomes a situation where they may be struggling and you think you're going to take it over for a longer period of time, like something complex has happened, or if there's a complication, I would say try to adjust it for yourself. But if your goal is to try to have them do as much as possible, my preference is actually to leave it at their settings. And, for whatever many seconds I'm doing it. But like I said, if it's something that I feel like I'm going to have to take over and maintain, scope control, then I adjust it for myself. And I do make those adjustments. It's a few extra seconds and it can make a world's difference. I just refuse to cut corners for my own like physical well-being, and, make sure that it's ergonomically optimized. But that's a really good question, like for the different fellows, but it's not impossible to like adjust bed heights. It's so easy now, you can do it without even looking. And a lot of beds for fluoro beds are electronics. You can even ask the anesthesiologist to do it for you. The more annoying thing is monitor heights, but this is all doable. You just have to make it a priority.
And as a follow-up, particularly as a leader, you're as a chief of interventional or chief of endoscopy for both of you, how do you recommend sort of initiating an ergonomics program into your unit, particularly if, there's so many players from the hospital involved? How do you get that going and get buy-in from leadership?
So, as Rabia said, some of the things are very low hanging fruits where, adjusting the bed, taking those few seconds to adjust it. And I encourage all my fellows to take it to their height. And the other is getting adjustable screens. So I think those are, having mobile screens, which for the longest time our unit didn't. And, we we sort of talked about it, looked into it, and we got that incorporated into our endo unit. So the key is, you have to recognize it and what are the shortcomings in the unit, and start with the easiest to do. Like a two-piece lead, when you're doing fluoro procedures, and encouraging fellows to do the things that you're doing for yourself, so they learn it sooner, and make it a habit, a good habit to keep.
So for me, for those who don't know, I'm on the smaller side in terms of size. So almost everybody on this webinar probably is taller and bigger than I am. So when I start with the fellow, typically we start with the settings for what the fellow is accustomed to. And then at any time that I need to take over, I actually change the stretcher height. I make them move the monitors. I make everything so it's ergonomically friendly for me, because obviously I'm ergonomically challenged compared to like a 6-foot male. So that's what I have to do. And luckily our unit does have adjustable height in terms of their screen, as well as the stretcher. So that is the only way to make it function. Unfortunately, when I was training, we had to set the table and the screens to our attendings. And basically I was told that I just needed to figure out a way to adjust. But when I became an attending, that meant that they had to adjust to me. I did not want people scoping on their knees, so I do make adjustments. So the stretchers and the monitors do adjust accordingly. But yes, I make a special effort to make sure that it's ergonomically friendly for everybody in the room.
That actually brings up a great question and topic. There was a great editorial in GIE about an article on recruiting more women and dealing with gender bias in the endo unit. And the title was, you don't have to change the women, just change the system. And I think, what you're speaking about speaks to that. And in general, when we think about ways to change the system, we look at leadership and recruiting more women into the field to provide perspective. Editorials or papers have shown that the top reasons that women are not going into endoscopy and advanced endoscopy are ergonomic concerns, pregnancy concerns, work-life balance. What are some ways that you think leaders, both rising women in leadership, as well as our male leaders and allies, what are some changes that they can make towards improving all the topics we talked about today: work-life balance and safety and comfort in the endo unit? Perhaps we'll start with you, Shivangi.
Yeah, so I think having a supportive work environment is very important, and understanding that there is a little bit more nuance when you have a female colleague or a female gastroenterologist. And I have been fortunate to be in a very supportive unit where when I was expecting, Rabia, I chose not to do ERCPs, and my male colleagues picked up my call and they totally understood. And it was, a decision that I made. So I think, just overall being supportive is important, understanding the needs of the female endoscopist. Like for the longest time, I was the first interventional female endoscopist at our institution, and there was no concept of a lead for me. All the lead were designed for the men, and I was like, oh, can I get my lightweight little body lead? And I made sure I got it hot pink so nobody else wanted to touch it. And I think little things like those go a long way. And now when I am hiring and interviewing, I make sure that they know that they have the kind of support, flexibility, that their colleagues are there in case they have to, go pick up their child early. I would pick up their case, and we have that camaraderie amongst ourselves and that support system.
I did the same thing. When I got my lead, it's hot pink. It's like the lightest lead possible. And I actually had the lead company come out 3 times to make sure they got my size correct, because they were doing sort of like the standard sizes and it wasn't fitting properly. So I actually had them come out and refit me to make sure it was, because we need to make sure that we're protected when we're doing all these fluoro cases.
Rabia, do you have any thoughts?
I do. I honestly, like, this panel is a perfect example of how much, to answer your question, your initial question about what programs can do. To be completely frank, hire more women in all fields, hire people who are from diverse backgrounds and be more diverse. Because the thing is, for someone like me, who was a fellow not too long ago, if I hadn't seen women like all of you, I would have never thought that being an advanced endoscopist and like a female and being like, you know, was possible for me, because if I'm not that creative. And so for so many human beings, if you don't see someone who looks like yourself or who behaves like you doing something that you want to do, you'll never envision yourself doing it. And so just to echo like what's happening in the world right now, representation matters so much. And so that's what programs can do. And even speaking to ergonomics, like if I have a fellow and that fellow, he or she sees me making a really big deal about ergonomics in the room, that's going to kind of imprint on their brain. And then they're going to think when they're in charge and they're in the room, that that's something that they should be doing for themselves as well. And that they're not being, you know, like dramatic and making a big stink about not being like a team player and just accepting the bed being like at their knees. You know what I mean? So what you do in front of people, especially when they're trainees, it's just so important. So like I said, if I hadn't seen people like you who are just killing it and advanced endoscopists and amazing and like great personalities, I'd be like, you know what? I don't think I can do this. It's like a male dominated field. It's not for me, but that's what I would do. Hire more, be more diverse.
Yeah, I think that, you know, as leaders, you have the ability to institute policies about when your meetings are going to be, about expectations with regards to RVUs, or even taking breaks and making sure that people aren't overworking, and creating a culture where discussing things like I need to take a break to go breastfeed, or I need a space to be alone for a few minutes, or I need some physical therapy type activities available. I think when you create that culture where there's dialogue and people ask more questions, you break myths. For example, I know that you asked for forgiveness for scoping during pregnancy, but that's actually been shown to not be a risk factor. And I think that the more that we know about that, there are plenty of women who have successfully not only scoped during pregnancy, but continued with breastfeeding during performing ERCPs. So the more that's talked about and discussed amongst our peers, I think the more we can break these myths, the more women we can recruit into this field, and then promote them onto leaders to create environments for us that will allow us to be successful. And I would say that, you know, that's what WIE is hoping to do, as you said, to provide that environment, provide those networks, the places to have safe and comfortable conversations, and also webinars like this, where not only are we visible to others to hopefully inspire, but also just to create that those conversations. And it's been a great journey so far. And I would highly encourage, there's so many webinars that I can think of, topics coming straight out of this that hopefully we can have so that we can really continue these conversations. But I would encourage anybody watching, again, to become a member, but also to send in some suggestions of ideas that you have.
So any final questions? I know we're really a little bit over time, but I wanted to make sure that if there's any burning questions, please put in the Q&A. And I think all the speakers can provide their contact information if you have further questions after the talk. I think this is an ongoing discussions that people are going to have, because I think it's a very relevant topic that's becoming very hot right now. So I want to take this time to thank everyone for joining us late in this evening out of your free time. A special thanks to obviously the two speakers, Drs. Kathari and De La Torre, for great talks on very, very salient topics. They're very on our minds. Obviously, thank you to Dr. Sethi and WIE for spearheading this webinar. And a special thank you to Ambu for sponsoring this webinar and being a great partner in this. So I think the biggest takeaway I got from the two fantastic talks tonight is that we actually, as a group, have to speak up and ask. We have to ask for help. We have to ask for time. We have to speak about issues that impact our ability to do our work and take care of our patients without having to sacrifice our own health, both physical and mental. And we also have to speak up to our industry partners to sort of consider the changing needs based on the changing demographics of the endoscopists they're scoping right now. When they design new scopes or design new devices, they really have to think about the entire spectrum of endoscopists and sort of the physical needs of the endoscopists currently. So again, I also want to make a final plug to encourage everyone to join WIE and be a part of this very supportive group of colleagues. And again, this session was recorded and will be available on the WIE website. And with that, I want to thank everyone for joining us tonight and have a great night. Thank you.
Thank you, everyone. Good night.
Good night, everyone.